objective of my today's talk is how cardiac CT and MRI can help in operative decision in different type of TOF cases. It is the most common cyanotic congenital anomaly, and every 2,000 live birth, one baby come with this abnormality. And if you look at here, this is the sagittal image, and this is the sternum and aorta. Main pathophysiology of TOF is anterior division of the coronal septum, which resulting malaligned large VSD and overriding aorta and RVOT narrowing and RVH. When CT actually is superior in demonstrating the complex cardiac and extracardiac anatomy, especially great vessel, but cannot measure the QPQS. And MRI mainly used in post-operative assessment, especially residual shunt, and determine the time of pulmonary valve placement. So pre-operatively, CT has 4 important roles to point out for important point. Like pulmonary artery measurement and degree of stenosis. Is there any pre-RVOT course of coronaries? And presence of MAPCA is, if there is a MAPCA, then size, course of the MAPCA, and is there any additional VSD? We know that TOF has a broad anatomical spectrum. Mild TOF means simple RVOT obstruction, and whereas severe TOF means pulmonary atresia, where pulmonary gets supplied from either by PDA or MAPCAs. And the surgery differ from conventional ICR or multi-stage reconstruction PS surgery. So here is, you can see that that is sagittal images and RVOT narrowing, and more appreciable in this view. And this is malaligned VSD with overriding of the aorta and main pulmonary artery, then left pulmonary artery, right pulmonary artery. These are all good size. And these 3D images, you can see this RVOT narrowing, and this is the RC and this is the LAD. So there is no crossing over the RVOT. So it's simple. ICR is conventional ICR was enough for this patient with good outcome. This is another case, is significant RVOT narrowing and VSD, but there is small MAPCAs for upper thoracic descending aorta. So for this case, conventional ICR is also enough good outcome. And TOF with pulmonary atresia, here is this is the LA and this is LV, and small size LPA and RPA, both are confluent and no pulmonary artery. And in 3D view, you cannot appreciate any pulmonary artery. And this is the malaligned VSD with overriding of the aorta. And what you see here, this right-sided aortic artery, multiple large MAPCAs, and one can easily measure the size of the MAPCA and also can trace the course. So for this type of patient, multi-stage reconstruction surgery is needed. Unifocalization of the MAPCA from the aorta into the central pulmonary artery. Otherwise, patient with lung will be flooded with blood after surgery, and weaning will be difficult. Here is another case. You can again appreciate the small pulmonary confluent pulmonary artery without any main pulmonary artery, and ascending aorta is quite big and small descending aorta. And so lung is supplied by the large PDA from distal aortic arch to LPA. And for this is a TOF with pulmonary atresia and PDA dependent. TOF with absent pulmonary valve usually present patient present with early stages with respiratory distress, because in absence of pulmonary valve, there is a marked dilatation of the post-pulmonary PA, and you can appreciate the large RPA causing compression over the adjoining bronchus, which possibly the cause of respiratory distress. So for this type of patient needs extra caution, have a plan. Surgeon should plan for reconstruction surgery of bronchus at the same time. So thoracic surgeons also needed during surgery. 5% patient come TOF with associated with anomalous pulmonary artery, and most commonly artery is RCA. And in first patient, this is 3D images, you can see that there is a narrowing at the RVOT, and RCA come from the left side and crossing over the RBOT. And here the same RC arises from the LAD and also crossing over the RBOT. So for this type of patient, need RV2 PA conduit instead of infundibulectomy to prevent the injury of the RC and the coronary ischemia, myocardial ischemia. Here is a patient with mild TOF, but right-sided aortic arch. It has a small clinical implication, but sometimes it produces difficulty for surgeon cannulation during surgery. So it should be mentioned in your report. So you can see that how CT can nicely demonstrate all the important 4 points preoperatively to guide the surgeon. And I said MRI is important in post-operative follow-up because it accurately quantifies the pulmonary incompetence, regurgitance, and also regurgitant fraction. It also clearly depicts the anatomy and RBOT. So this is the post-op CMR in sagittal view, and you see that there is no stenosis or residual aneurysm. Wherever in these cases you can see that there is an aneurysm in the RBOT. This is the common complication after surgery. And one important point, CMR can quantify the regurgitant fraction and the regurgitant volume by spatial phase velocity mapping sequences where perpendicular sequences taken along the long axis of the main pulmonary artery. Then flow is measured and you can see the antegrade flow and retrograde flow and easily calculate the regurgitant fraction by dividing this. And if the regurgitant fraction is more than 40%, that patient needs valve replacement. Thank you very much. Before I stop, I would like to express my gratitude to IPDI organizer, especially Dr. Mohsin and Professor Wadu Chaudhuri, inviting me in such a huge festive. Thank you.